idea of what today's first two speakers are going to talk about. It's cancer prevention strategies as well as cancer burden and HPV. Okay, so our first speaker is Dr. Jacopo Balsano. Dr. Balsano is an infectious disease physician and epidemiologist. He's the leader of the public decision modeling team within the Early Detection, Prevention, and Infections branch at the International Agency for Research on Cancer World Health Organization in Lyon, France. Before joining the agency in 2012, Dr. Balsano worked at the Center for Oncologic Prevention in Turin, Italy, and at the School of Public Health of the Imperial College of London, UK, where his investigations were mostly focused on infectious disease control among vulnerable populations in both high and low middle income countries. In the field of cervical cancer control, he combines quantitative and predictive modeling with field epidemiology to assess the impact of HPV vaccination and HPV DNA-based screening in both high and low middle income countries. Dr. Balsano is also actively engaged in knowledge and technology transfer from high income countries to low and middle income countries. I think we can do, and then I can introduce her before.
Okay, thank you. Good morning to everyone, and thank you for coming at this 8:30. And I want to thank the organizers for inviting me, first of all. I will give this presentation in English with an Italian accent, so I hope you can understand. Okay, so yes, this is going to be a presentation. I will present data from and evidence from Armenia, but first of all I want to try to put them in the global context. But I think what is important is that normally we had the global context, but nothing from Armenia. This time we have data from Armenia. It's a work that has taken a lot of time, a lot of energies from us, from the support of Ministry of Health and from FIDEC Armenia, which helped us a lot with the field work. So I have no conflict of interest to disclose. And then I have a video to show that summarizes for lay audience what we have done. And it's also, if you one day you want to share this link, I think it's very important. Can you please? The International Agency for Research on Cancer, within the initiative of cervical cancer elimination of WHO launched a few years ago, has been developing field studies and in collaboration with local Ministry of Health and institutions in order to assess the burden of HPV infections in these countries and the potential impact of HPV vaccination.
FIDEC stands for Fighting Infectious Disease in Emerging Countries. It's a non-profit organization. We started our activities here in Armenia nearly 15 years ago. The first part of the study was completed, and now we are in the middle of the second part in order to have results for the whole study. This information is going to be very important to the country in order to have a real spectrum and picture of the infection. And with this information, the public health can develop and can make recommendations specific for controlling this infection.
Մարդու պապիլոմավիրուսի տարածվածության վերաբերյալ հետազոտություններ Հայաստանի Հանրապետությունը երբևիցե չէր իրականացվել եւ ներդերման փուլում մեզ շատ հաճախակի հարցնում էին ինչի հիման վրա է կատարվում այս ներդրումը եւ մենք ոչինչ չունեինք ասելու պարզապես բերում էինք փաստեր որ միջազգային կան հետազոտություններ տարբեր երկրների փորձ էինք բերում եւ շատ ուրախ եմ որ արդեն Հայաստանի Հանրապետությունում մենք վերջապես ունենք մեր տեղական հետազոտությունների վիճակագրությունը եւ վստահաբար կարող եմ ասել որ այդ հետազոտությունների արդյունքները մենք օգտագործենք հետագայում որոշումների կայացման, նոր փոփոխությունների քաղաքականության փոփոխությունների կատարման եւ նոր ռազմավարությունների մշակման համար։ բայց կարծում եմ շատ այն ավելի օգտավետ կլինի նաև բնակչության հետ աշխատանքների կազմակերպման, իրազեկման, հաղորդակցման միջոցառումների իրականացման ժամանակ, որովհետև հենց նույն մեր հիմնական դերակատարողները, բուժաշխատողները իրենք էլ են շատ շահագրգռված ունենալ տեղական վիճակագրություն եւ դրանով իրենց համար շատ ավելի հեշտ կլինի բնակչության հետ աշխատելը, մայրերի հետ աշխատելը եւ նաեւ մեր թիրախային խմբի հետ աշխատելը։
Շատ խաչելի է, որ պապիլոմավիրուսի տարածվածությունը Հայաստանում այդ հետազոտությունը կատարվում է։ Մենք ներգրաված ենք այդ ծրագրի մեջ։ Իմ կարծիքով շատ հետաքրքիր ծրագիր է ու կարևոր, քանի որ ստատիստիկ տվյալ չունենք պապիլոմավիրուսի տարածվածության մասին Հայաստանում, ու ընդհանրապես Հայաստանում իմ կարծիքով քիչ է կատարվում հետազոտություններ։
Ուրախ եմ մասնակցել այս ծրագրին եւ իմ նման ունենալ այս հետազոտության մեջ։
Thank you. Okay, so now we have the full picture. So, globally, cervical cancer is the fourth most important cancer for women worldwide, but in low-middle income countries often is the first. Now the breast cancer is also coming. And as you can see in the map, there is a lot of heterogeneity across the countries in terms of incidence. But as you will see, there is more heterogeneity about mortality given a certain incidence. So you have some numbers. So you have more than 600,000 cases estimated. These are estimations in 2020 worldwide. And as you can see, the annual standardized incidence rate is a bit higher in low HDI countries. Sorry, the slide is here. You can see it better. Okay. Whereas in very high country, the incident, the age standardized is a bit lower, but they are comparable if you pull them together. So the highest level of development with the lowest level of development. In sub-Saharan Africa, the co-infection with HIV makes the situation extremely dire and important. But when you move to see mortality, I think it's important to observe the gap between the blue lines and the red, okay, or pink lines. But the difference in low income and high income, it's immense. Why? Because if you detect a cancer early through screening, then you can act. Whereas if you don't have screening working, basically when you detect the cancer, it's too advanced, and the survival to this cancer is much lower. Here you can really see the importance of prevention. In this case, secondary prevention. We will also focus on primer and the vaccine, but I think these slides tells a lot. We don't have to only to think about the cancer as the curse, but also the natural history, so the death at the end of the day. Now, here for people who do not spend their entire life working on HPV and cervical cancer, like me, but you know, there are other doctors doing also treating other infection or other disease, I summarize the natural history, and then I will focus on two important points. So there is, of course, the normal situation, uninfected by the HPV. Then there is a moment in which there could be or not an infection. Most of the infection, 90% of the infections, are cleared in 2 years. So an HPV infection, in particular at young age, is more or less like a cold. I mean, it happens and it goes away. But in some cases, it remains, and it can evolve through lesions, HSIL in this case, and then to cancer. They can be prevented in two ways. The infection can be prevented by prophylactic vaccination. There are now 3 vaccines which are licensed. There are more coming. Or they can be controlled by cervical cancer screening. Now, there are bivalent and quadrivalent vaccines which cover 16 and 18, which are responsible for approximately 70% of all cancer cases. These are world data, but now we have data from Armenia showing that is exactly the number of cases attributable in Armenia, you will see. And then there are other 5 types which are responsible of another 20%, and they are covered by a larger spectrum vaccine, the non-avalent vaccine. And again, we have the Armenian data confirm this number. And then the cervical cancer screening is moving ahead using HPV DNA-based detection, which is accurate, easier to perform, less expensive, and can be done on self-sampling, which is much more acceptable to women. Now, the point is, when people do some kind of cost-effectiveness analysis, is that the intervention and the prevention is not like preventing measles among children. It takes years. So the investment will give a feedback and will give an impact later in life of the woman, but still there is a strong impact of prevention. The availability of a vaccine and the availability of an HPV DNA-based screening allowed the WHO to launch the initiative of cervical cancer elimination as a public health priority. And it's based on 3 main goals, which are inspirational. Sometimes they can be met fully, sometimes they cannot be met fully, but still they are a target to aim at, which is 90% coverage of vaccination of women below the age 15, 70% of screening at 2 rounds of screening by age 35 and by age 45, and then 90% of treatment of women who are either diagnosed with the precancerous lesions or with the cancer. Of course, the implementation of these 3 elements goes in parallel, and sometimes, you know, it's much more difficult, for example, to have a complete system of treatment, and therefore is why it's wise for Central Minister of Health to invest more on prevention, and then you know, to have the rest of resources invested on the treatment. But this is a local decision according to the local facilities. Now, what was the HPV vaccination status in 2019? Here you have a picture. Then COVID arrived, so everything was disrupted worldwide. So now having a map of what is happening is a bit more complex. But before COVID, this was the situation. 55% of all the countries in the world had introduced vaccination. Among those who had introduced vaccination, 67% had the first dose. There are evidence that 1 dose is sufficient to protect from HPV infection, 16 and 18, and then 53 had the final dose. Now, there are very few countries which have reached 90%. Of course, it remains the aim, but you know, there are several countries which managed to reach 75%, which is quite high. And then the rest are above the 50%. Another option which is now being explored is not being adopted worldwide because there is a lack of doses, is also to move vaccinating boys, which also protect them and protect the girls in the same population. So what is the cancer screening status? The cancer screening status is much more complex. Basically, the screening is regularly applied in high and middle income countries, much less in low income countries. I think the most important figure is the one you have below, is that 1.6 billion of women, so 2/3 of the human population in terms of women, have never been screened. And this is a big issue. So, what is the expected impact of HPV vaccination? Now, we expect, and this is an idea that we had when we were visiting Armenia, this kind of analysis, is that among girls who were born between 2005 and 2014, so young women working in the street today, essentially we expect to have 8 million of cases in low-income countries in absence of vaccination, 3 million of cases of cancer lifetime in high-income countries, and 1 million in very high-income countries. But between 76 to 77% of these cases could all be prevented through vaccination. On the table on the right-hand side, you can see the same calculation. We did a calculation for every single country. You have the numbers for Armenia. So over 10 birth cohort, we expect, roughly, with our confidence interval, 1,875 cancer cases, and among them, if you use bivalent vaccine or quadrivalent vaccine with perfect coverage, the highest coverage you can have, then 75% of all cases could be prevented. If we have a non-valent vaccine, then 90% of these cases could be prevented. And these are women which are still vaccinable today with a great impact. Because even if they are HPV positive, most likely they will lose the infection and they can be protected from the next one. Okay, now these are the typical questions I get. Does it work? Yes, it does work. And there are evidence from Sweden and now also from UK and other countries that it prevents not only infection, but it prevents cancers. As you can see here, the risk that you have in girls who are unvaccinated, it's the orange line, is much higher over time than the risk that you get when you are vaccinated at the proper age, which is less than 70 years. These data are published on the New England Journal of Medicine and are very compelling. And then there have been publications from UK and other systems showing exactly the same thing. Is it safe? Yes, it is safe. There are very few adverse events, very few severe adverse events. If you want, this is the most updated reference. And then a question that I always have: does it increase sterility or fertility? It does not. There are no evidence that there is an increase of infertility among vaccinated women. On the contrary, it protects from from a sexually transmitted infection. And from interventions of screening, which can decrease the fertility. And then, does it have an impact? Then we will see the data in the impact. I will reply with the next slides coming. So, to assess the impact, we have done several surveys in the world. We are measuring the HPV prevalence before the introduction of vaccination and after the introduction of vaccination. We are completing this kind of initiative in many settings. We have done it in Bhutan and Rwanda. I will show you one slide in which we can measure the impact, and we see that there was a strong impact. Armenia is the third country helped by FIDEC with which we worked, and we have the baseline now. We have the evidence of the burden of HPV, and then we have launched this initiative also in other countries. And other institutions are doing the same in other settings, using exactly the same methodology. The same methodology is standardized. We have a baseline survey, which is the dark gray vertical bar that you can see in the top graph. So we measure within a certain age the prevalence of HPV infection. Then, if there is vaccination, we wait that the girls who are vaccinated reach the same age, and then we measure again the HPV prevalence, and we make a comparison. And if there is a decrease of this HPV prevalence, then there is evidence of impact of vaccination. We have also standardized approach in terms of analysis of the data, and you can find everything in the reference that you see below if you are interested in understanding a bit better what we are doing. What is very important is we can measure the overall impact of vaccination. We can measure the herd effect, and we can measure the direct effect of vaccination if we have information about the vaccination status of the woman. And this is why it's important in countries, for example, like Armenia, who has the potential to do it, is to have a vaccination registry. There are countries which cannot afford it, they don't have the infrastructure, but if you have the infrastructure, it's good to have a vaccination registry. It can help a lot and will pay off in the future. And I know here it's possible to do it because we had discussions when we were here doing the studies. So then you have standardized outputs. You can see on the right-hand side, basically two graphs, one from Bhutan and the other one from Rwanda, and the curves in which you see the arrows. Does it work? The downward arrows in red shows the decrease of HPV prevalence in vaccinated birth cohort. Okay, you have in Bhutan, so you have a couple, sorry, I move it. These curves here and these curves here shows the prevalence before the vaccination, and then you see the curves after the vaccination. The HPV infection is disappearing from the vaccinated birth cohort. The curves above are control HPV, which are not affected by the vaccination, so they shouldn't change. Maybe they increase because the behavior changes, as there, but here you can really see an impact. And this will translate in a reduction of cancers in the future. And we can even quantify how many cancers can be prevented with mathematical models. And this is what we have done in this publication. I'm sorry, the pointer doesn't work, so I cannot show. So it's here. Okay, we can quantify the impact. We can quantify the impact in terms of cancer. So once we have this data, which is fairly simple to get, then we have a lot of return in terms of analysis, prediction, and this is good for the organization of the prevention at the ministry level. So what we did in Armenia, we did two studies. One among young women using urine to collect the samples. Another one with adult women, older women, between 21 and 29, using a cytology sample taken by the doctor. The recruitment process was very simple. There was an invitation from the basic health center. We had a list of the women who could be invited. They were randomized and invited. If they accepted to participate, they signed an informed consent and then they gave a sample. There was a very short interview. Everything was kept anonymous. And then all the samples and the interview were stored and then they were analyzed. And in this, I repeat, in this kind of process, FIDEC was very, very supportive, and essentially they ruled the study in collaboration with doctors, as you have seen in the video, and that helped us a lot to ensure the quality of the data that we have. So you have two flow charts. Essentially, this is what happened. The urine survey was conducted at the beginning in 2019. Then we have a second survey in 2021 and 22. And now, basically, at the end of the entire process, we had about 2,500 young women who provided urine, and we could use them because they were qualitatively good enough to be analyzed, and we had data from the questionnaire. And for the older women, we had about 3,000 samples and questionnaire which were valid. And this is the denominator we use for our analysis. We also can calculate the participation rate, but these data are still in analysis, so we don't have the exact number now to present. They will be presented in the publication. Okay, just to give you an idea, this is where we conducted the study. Mostly in Yerevan, and then in a couple of other urban areas. As far as we could, we used exactly the same centers to have an overlapping population. In some situations, we could not, because they didn't, basically, we had, in one case, we had a pediatrician or a GP. In another case, we had gynecologists. So, I mean, sometimes the population are a bit different, but as far as we could, we used exactly the same centers. And as you can see, the age range do overlap in such a way that we could have data from the youngest age to the upper age to have a trajectory of the HPV prevalence in the country. Okay, and now here we start with the results. So what is Armenia doing in terms of HPV? Here you have a series of studies that we have done over time across the world. Okay, we have more than 30 studies. Armenia is spot on the middle. So Armenia is, like most of European countries, in terms of HPV prevalence, is exactly in the middle. So on the top you have Guinea, Mongolia. In the bottom you have Vietnam and Pakistan. Armenia, and is very reassuring, is close to Georgia. Everybody told me before we started the study, well, we're going to be like Georgia, because there is this big similarity. And so that ensures, it's like an indirect idea that there is a validity of the data. But then it's in the middle. And these are the HPV 16 and 18, which are the red, which are the preventable through vaccination. These are other types which cause cancer, some of them preventable from vaccination. These are other HPV types which do not cause cancer. But having this level is important in terms of cancer. It generates a burden of cancer, which I will show you later. So there is room for public health interventions and prevention, given the data we have. How does it work in terms of age? Here you have the age distribution. On the top you have all types of HPV. On the bottom you have only HPV causing cervical cancers. And as you can see, and as is expected, you have an increase. 17 is very low, and then it increases. Here the two age overlap, but to significate the difference, this is urine-based and this is cytology-based. So you have an increase. The top is at 22, and then there is a plateau. And this is typical. You can analyze the curve in any European countries. This is the way it works. It can go up a bit earlier, around 19, 20, but then it stays until 35, 39, it stays like this, then it starts decreasing. If you take the curve in Italy, it's exactly the same. You take the curve in France, it's exactly the same. So essentially, Armenia behaves like any other country and needs public health intervention to control cervical cancer. Then we have applied mathematical model to move from these curves to expected number of cancers in the future. And this is what we expect in the next 10 years in women who were 20 to 24 in this analysis, 25 to 34 in our survey, and then 35 to 44. So the next 10 years. The red dot that you can see here is the predictions based on the map you have seen before. It works well for the first two age groups. But for the last age group, we expect an increase of cancer risk given the HPV prevalence. These are infections that are already there, so they can be prevented through screening, not through vaccination. The future infections will be prevented through vaccination. Then, the point is, what is the distribution of HPV types in Armenia? So, do the vaccines that are available now protect from the types of HPV which causes cancer in Armenia? So we worked in close correlation with, in close association, with pathologists here in Armenia. They retrieved for us blocks of cervical cancer in paraffin. These ones were analyzed. They were sent in the top laboratory in the world, which is based in Amsterdam, to do this kind of analysis. All the diagnoses were double-checked blindly, and then the cervical cancer were typed. So we were looking for the HPV types in the cancer. And this is why we have 231 blocks. Then there was a quality control, and we ended up in using 185 samples. This one, they could be typed. And here are the results. The table is the most important. As I said before, approximately 70% of all cancer cases in the world are attributable to HPV 16 and 18. This is exactly the case in Armenia, 71%. So the introduction of vaccination would decrease the cancer attributable to this type, the cervical cancer, by 71%. And then you have the other 5 types, 18%. These are protected by non-avalent. So if you sum them up, 90% of all cancers could be prevented by vaccination. And then there are the other types. I want to stress one point, which is very important. It's not yet studied in Armenia fully. We are studying it in other places, and I think it deserves to be studied here. There is a lot of financial toxicity associated to cancers in general, but these cancers affect women in a relatively young age, in which they have a fundamental role in the society because they lead a family, they raise a family, they work. So having someone dying of cervical cancer around 40, 50, 55, it has a tremendous impact. And this is unquantified. And most of the cost-effectiveness estimates that you can see around the world have a perspective of the government. How much money do I put in the hospital? How much money do I put in the vaccine? But they do not consider the impact that you have in the family. So how much money is lost by lost income, having orphans and all these things. And this information can be collected. It doesn't cost much. So we are planning also to try to collect this information in the future. But when you think about the general problem of preventing cervical cancer, there is also this very important impact. So the conclusions are that the reported findings provide an extensive assessment of the actual burden of cervical cancer in Armenia. These are the most updated data that you can have. The reported findings provide also a technical sense of what is preventable of this cancer in Armenia. The epidemiology of HPV and cervical cancer in Armenia is absolutely in line with what has been observed with any other country in the world except the countries where there is a lot of HIV. But otherwise, it's really a paradigmatic situation. Then you have HPV vaccination and cervical cancer can prevent, and they are cost-effective. They are best buys for the WHO. So they are extremely cost-effective, if not cost-saving. Intervention could eliminate cervical cancer from Armenia. And then the last point is the elimination of cancer from Armenia would also prevent financial toxicity within the country. And finally, I would really like to acknowledge the role of all the people who worked with us and made this possible, because otherwise we would have not been able to do this work. And thank you for your attention.
Thank you very much, Dr. Balsano. It's great to have estimates for HPV burden, and hopefully that will help increase vaccine uptake now in the country. I forgot to mention earlier, but we will have a Q&A session at the end of 4 speakers. So please write down your questions or keep them in your mind, and then we'll have the Q&A session at the end. Okay. I think that was the only thing I forgot. Our next speaker is Nora Pashayan. She is a professor of applied cancer research and honorary consultant in public health medicine at the University College London. She's the head of the UCL Department of Applied Health Research and the director of training for the International Alliance for Cancer Early Detection. Nora has studied biology followed by medicine at the American University of Beirut. She has specialized in both family medicine and public health medicine. She has completed master's in epidemiology from London School of Hygiene and Tropical Medicine, and in public health from the University of Cambridge, and PhD from the University of Cambridge on modeling the natural history of prostate cancer and implications of using genomics for cancer screening. Nora's research is in cancer screening, in risk stratified screening, in developing screening strategies to improve the benefit-harm balance and the cost-effectiveness of screening programs, and in ways of implementing such programs.
So the pointer works, but you just can't see because the light's from behind. Thank you, Anya, for the introduction. Ուրախ եմ, որ հոս կգտնվիմ եւ շնորհակալ եմ օրգանիզներ գազագերբիչներեն հրավերին համար։ Okay, բայց կներեք, որ այսօր անգլերենով պիտի ներկայացնեմ։ All right, so we'll start with giving some introduction to the burden of cancer in Armenia, some aspects into introducing a screening program, and some of the future directions. So for a population of around 3 million, in 2020, it was estimated that there were around 9,000 cancer diagnoses and 6,000 cancer deaths in Armenia. If you look into the most common cancer types, in men, the usual suspects is lung cancer, followed by prostate cancer. Also, we do see stomach and bladder cancers as among the top cancer types. In women, breast cancer accounts for more than a quarter of all cancer cases. Also, there is an uterine cancer and stomach cancer among the top cancer types. And if you look into the mortality, the red bars, we see that these cancers, lung, prostate, and breast cancer, are important contributors to death. What is interesting is that to see in Armenia, the cancer mortality is among the highest in the region and the 17th highest in the world. So one way to look into understanding the mortality, to understand the burden, is to look into the mortality to incidence ratio. This is an indirect measure of case fatality, and it enables us to compare between countries. So we see that lung and stomach cancers are killers. Most of the people who have these cancers die. But I was surprised to see breast, prostate, and colon cancers to have much high fatality or death accounted to. Now, to understand this, I wanted to put into a perspective. So I went into comparing two places. One is the UK, where I come from, and therefore what we see is that, yes, lung and stomach cancer are high mortality to incidence ratio, but also you can see that breast and prostate, they are not as much killers as in Armenia. Now, you might say, therefore, it's not a fair comparison to compare to the UK. So I've gone into another country, and which is troubled economically and in political situation, and this is Lebanon. Also, this is a country where I come from. So Lebanon does not do much better than Armenia. However, still it's a bit better. So there is a scope for improvement for Armenia. Now, the next question is, why do we see this? Therefore, try to understand what's happening. A part of it is to do in cancers is because there is a delay in diagnosis. And if you look into the cancer diagnosis in the stage, most of them are diagnosed advanced stage in Armenia compared to other places where they have a better mortality to incidence ratio. Another factor to consider is looking in the latest survey. In Armenia, I was surprised to see 51% of men are reported as current smokers. Women are 3%, but of course there would be second-hand smokers, so they would bear the consequences too. H. pylori is a common in Armenia too. So what can we do? So there is a personal approach is prevention, particularly if you look into the population attributable risk, which is, for example, in tobacco, 28% of cancer cases are due to smoking. And this is followed by infections, could be HPV and H. pylori, which account for 12% of cancer cases in Armenia, followed by obesity and alcohol intake, each account for 5 to 6% of the cases. All of these are modifiable risk factors. All of this, working on them, could reduce cancer burden by at least 40%. But even if you do this, still it needs time to see the effect. We need 10 to 20 years. So it's very important to have early detection of cancer. But having an early detection itself, it doesn't give us impact unless we have timely and accessible, effective treatment. So I'll move on into when I say early detection, what do I mean by? If you look into the cancer progression, so there is a time when there is cancer, but there are no symptoms, and then over time, there could be developing symptoms. For example, feeling a breast lump. Now, of course, the more the symptoms are there, it's easier to diagnose a cancer. However, the prognosis is less good than diagnosing a cancer earlier when there are no symptoms. Now, when we talk about early detection, it could be early diagnosis. And this is for people who have symptoms, but it takes them time to recognize the symptoms are important and they need to go and see a physician. And for the physician to suspect that there could be a cancer, to refer them for investigation and diagnosis. So we want to shorten this amount of time. But also there is in early detection, we have screening. Screening is about you have your population who don't have any symptoms, and you want to give them a test to identify, to see who has a cancer early on. But the purpose of any screening is not just to detect a cancer, it's to detect a cancer that you can do something about it. You want to prevent cancer death and to improve quality of life. Remember that screening is a sifting process. Basically, with screening, you get a probability, but you need to have a follow-up confirmation diagnostic test. And in screening is not just one-off test. It doesn't work as that. So you need to have repeat taking up after interval of time. So basically, it's a call-recall system. But most importantly, screening is not about a test. Screening is a program. So if you have a test, it doesn't mean that you have a screening. We need to look at it as a program, and I'll come to this. So when we have we want to set up a screening program, what are the things we would consider? Of course, we would consider what is the disease, because we don't have screening for every condition. And this is what we look into: how common is the condition, how common this particular cancer, for example, and whether we understand the natural history of it. We need to see if we have a test which is simple to give it on a population level, and it's acceptable, and we can afford it. And there is a treatment afterwards, and the treatment could prevent the death and improve outcome. But more importantly, also, we need to look into the program as a whole. And what do I mean by repeat saying program? In a program factor, we need to look if there is the infrastructure. Infrastructure includes the workforce. And the workforce is not only you have a cancer screening, you have all the people involved, from administrator to manager, to the clinicians, therefore clinicians with different specialties, primary care, the cancer oncologist or other specialties, anesthesiologists, all the people. You need to have also the labs, the diagnostics. You need to have the system of data registration, cancer registration or registering income. So the second aspect in the program, we look into the coordination and integration. So screening is not just a test, because you need to send positive findings to refer to investigation and then refer them to treatment. Therefore, it need to be all this in a coordinated so that you can have this, everyone receives the needed attention in a timely fashion. And if possible, to have it integration, for example, with preventative measures. And a screening program would not work if we don't have a quality assessment or quality assurance system and a performance monitoring system. If we don't know the quality is not working, no matter what you do, we will not see the impact of the work you've done. Another factor we look in screening is the benefit to harm ratio. Yes, screening, if we have a screening program, it should reduce the cancer death, but also with screening, there are potential harms. And the potential harms are, as I said, it's a sifting process, so therefore there will be some false findings, whether there's someone who doesn't have cancer will test positive, or someone who has a cancer will be missed. And this is inevitable. So another potential harm is the overdiagnosis and treatment of overdiagnosed cancers. And what we do, I will explain what these are, but what is important, we need to have a program that does more good than harm. And also, we need to do a budget analysis, budget impact, to see whether the program is affordable to the particular country, and whether the program is cost-effective, it's value for money. And you want to adjust the way you do, depending on what test you're using and your screening strategy, to make it more value for money. You need to look whether this program is acceptable to the public or the participants of screening, and acceptable to the providers. Otherwise, if they are not have a buy-in, this program will not work. And also, we need to ensure that there is an informed choice. When people have the choice to participate or not, provided that they understand it's not based on misconception or misbeliefs. And of course, all this, we need to ensure that it is accessible and it does not create inequalities. It is equitably accessible, in the sense that we don't want that people who can afford, they can go and get the treatment or the screening, and people who can't afford, probably who are the highest risk for having these cancers, are not getting access to the system. So I'll move on a bit into understanding the natural history. What do I mean and what are the implications? So imagine there is a schematic diagram here. We have a time when there could be a cancer, but we can't detect it. And there is a time when we can detect a cancer. Think about the mammogram. For example, to see it on a mammogram, you need to have a breast tumor size around ½ centimeter. And then over time, the tumor may grow until they manifest with symptoms like a palpable mass, I said. This interval of time, when the tumor is screen detectable, to the time it would have been diagnosed clinically, is called the sojourn time. And it's important, it tells us, this gives us the window of opportunity of screening. And it tells us how often we can screen. And of course, the sojourn time is different for different cancer types. In breast cancer, it's around 3 and 3.5 years. Prostate cancer is a slow-growing tumor, it's around 10 years. And even with the same cancer type, different individuals will have a different sojourn for time, and that's why different individuals will have a different benefit from screening. When you apply your test, a person is an asymptomatic, so basically you're applying the test and sometime within this sojourn time, and when you detect a cancer, you advance the time of diagnosis by amount of lead time. Remember that a person can die from other causes at any point in time. So if you have a screening, so you do screening, we need to have a repeat. For example, let's say you do repeating screening for breast cancer. In the UK, we do every 3 years. So if your tumor has a sojourn time of 3 years and plus, it will be picked up by your screening program. If it has a shorter, it will be missed. So all we see is the blue lines, therefore the longer ones are the long sojourn time. If someone has a sojourn time, it's a very long one. if they were even missed because a test misses a cancer, they have a chance to be picked up a second round of screening. And these are the ones that are already are good prognosis tumors. But the important thing to say that the shorter time ones, often they are missed. They appear in between screens. Someone who tested negative, before the next invitation, they've come up with a cancer diagnosis. So these are the interval cancers, and interval cancers are important to monitor the quality of the program. So if you do screening and most of the cancers are coming up in between your screens, it's wasting your time and your effort. And therefore, we need to do accordingly to either screen more often, shorten the duration of your interscreening, the interval of time, or also improve the test performance, the sensitivity of the test, to pick up the cancers that are there in the preclinical phase. Now, overdiagnosis, as I mentioned, what is it? It is a cancer that is detected by screening, but otherwise, if there was no screening, this cancer would not have been picked or appeared clinically during a person's lifetime. So the person would have lived and died without knowing that they have a cancer. And this can happen either because the cancer never progresses, stays as it is, we call them indolent cancer, or is it that the cancer would have progressed to become clinically manifested, but it happened that the person died from some other causes. So basically we see that it depends on if the lead time is longer, basically, than the remaining life expectancy. So basically, an overdiagnosis will depend on, one, the cancer factors, the sojourn time, and also it depends on the person factors, which is the age of the person when they were detected, and depends on comorbidities, which will define the expected life expectancy, remaining life expectancy. And also a function of the screening program, it depends what age you screen and how often you screen. The older age group you screen, the higher probability of overdiagnosis. The more you screening episodes, the higher overdiagnosis will be seen. But again, when you screen more, you get also more benefits in reduction of mortality. And that's the trade-off. The trade-off is how much you want to compromise in benefit in order to gain, to reduce the harms of screening. Move on into setting up a screening program. This was done by the International Cancer Screening Network in Asia. So they've come into a consensus of identifying, if you want to set a screening program, what are the factors you need to be considering? Of course, one is the screening policy. And what do we mean by policy? Is that we need to have everything about the screening strategy. Who will be screened, when and how often. We need to decide on whether it's going to be an organized screening program, where you have your population, you send them the invitation to come to screening, or are you going to be an opportunistic case finding when a person goes to the physician and say, oh, by the way, have you had your screening? And then they will be given. It's a decision. You need to decide on how this is going to be financed. Is it gone by out of the pocket, or it's covered by insurance, or it's covered by the government? And also every process of the screening, the nitty-gritty details should be in this policy. Remember that the cancer we need to have, it's not just a detection of or a test. After the test, we need to have clear about how you're going to follow if there are abnormal findings, and also how you're going to follow up the treatment for these people. And we need, as I mentioned, the infrastructure for implementation, and this with from health professional to all the processes in place. The monitoring system. You need to decide what are the standards that you want to say. You need to decide what is a positive finding and how much interval cancers you can accept, how much false findings you can accept in your program, and what is how much you want your target of screening to be. For example, in the UK we say 80% uptake of screening for cervical. You need to put the standards and you need to monitor against them. To do so, we need to collect a minimal data set that you can to ensure the elements you can monitor. If you don't know what you don't measure it, you can't improve it. Of course, this would require an IT or information system in place. No matter how good is your program, if you don't engage the players, the public, it doesn't work. They need to be a partner. So whenever you develop, however you're going to do, you need to engage with them. They should be co-partners in co-developing all the strategies and the way to do. And implementation of any screening, you can't get a copy from one country to another country. It is very much context specific. It will be therefore, and things will change, and you need to have the research going on, how you would be improving to specific to your situation in a specific country. Now, whatever it is to do, you're going to implement this program, there are 4 players. One is the public. You need to know how much they know, the information they provide, the stigma associated with having a cancer, especially when you have a cancer with like smoking and lung cancer it comes with. And it depends on their ability to pay. If there's going to be out of pocket, it has implications. We need to consider the providers, whether they have the capability, the training, the need, the competency, and also there is a capacity. You have the different specialties and enough number of people who could do. The healthcare factors, of course, you need to look whether the policies, the resources, and the infrastructure available for implementation. But we need to think also above, beyond the healthcare. We need to think about the whole country, this system, because it's all depends on priorities of the country. For me, screening is very important, but there are other priorities. It's not the government's priority may not be the screening, the cancer. They have other conditions to look. It's not only health. There are other things and they have to set what are the priorities. It depends on social, political, economic situation of the country. It's a political decision when there is funding or not. It's a therefore also there's a small p and large p politics are involved in there. Now, screening in Armenia, I'm no expert. I've just been reading that for you people who are from here, you are the experts here, but just I've known that there is a systemic or organized screening program for cervical cancer, but the coverage may not be as good as you would want. Breast cancer, I hear yesterday there are efforts to introduce the breast cancer more on an organized basis. At the moment, from what I've read, therefore most women have not had their mammogram, and those who had, there were those had out-of-pocket payment, and that's the challenge. If you want to study the barriers, therefore this wasn't a study done in European countries, look using the tool, barriers to effective screening tool. Basically, you need to look into every steps of the process. How do you communicate? How do you invite for screening? How do you ensure there is an informed participation? The running of the program, follow-up for treatment and for follow-up. And different European countries, different regions, but all we can see there are issues with participation has to do, for example, it's not for the values, beliefs which affect participation. It has to do with the operational aspects, whether they have the infrastructure, the system is in place. It's a complex to run a program if you're running it. Therefore, they have all the systems playing all together. So there are different components which affect. But if you want to summarize this, you can look into barriers in 3 different levels. Barriers to do with intention barriers. So here we have the public motivation and priorities. What makes people to come? It depends on, one I've said as, do they have the access, the travel? Is it time out of work for those who work? And is it out-of-pocket payment? You need to look into the way information is provided. Where do they get their information? So it depends on their experience with the healthcare. If they have a trust or mistrust issues, and accordingly, they will be engaging or less engaging. It depends on the experience of friends and family. They have a very much influence on people, how they will engage or not. It depends on what they hear on the media, and they make their minds. It also depends on the health belief. People where they think they are susceptible to have cancer, and they want to take it, and also depends on their belief about cancer screening. Do they think this works or not? That this will make them to come or not to come to screening. It depends on how do they look into cancer. If cancer is seen as deadly, therefore to say it's a fatalism, therefore no point in going into screening because anyway I'm going to die. So we need to be considering to look into what's going on to come up with intervention to overcome these barriers. There are also the barriers looking from capability, which is looking into the workforce. Even if you have this needed specialist areas, we need to see the geographic distribution. If all of them are in the capital, then there is still a problem. Resources, again, the different resources, whether you have the transportation, distribution of the specialist centers, the infrastructure. The third factor is the health system barrier. Affordable, is it available, is it accessible things. Even if it's available, is there a waiting time for this, which will make less available practically? So if you're going to improve existing programs, maybe you want to have a better test, therefore you want to look into how the test could be not to miss cancer cases, but at the same time not compromising on the specificity, which is if there is a cancer, not to give a false findings, and you don't want to have lots of people coming and having an investigation, because this puts people to, less likely to come for the next round of screening, other than it has cost and distressing. Improving in communication will pay up, and also evaluation, timely evaluation of the positive findings. I don't want to go there. Therefore, in breast cancer, there is now the discussion of having an MRI in addition to mammogram for those women who have a dense breast. In colorectal cancer, for example, in the UK, we moved from a fecal occult blood into fecal immunohistochemistry test. The reason was there was a low uptake. With fecal occult blood, we need 3 samples. It's not pleasant to do it. And with FIT test now, the uptake has increased tremendously. Cervical cancer, the self-sampling is the way forward, I think, therefore, for people who don't like to go, they don't have an access, or they don't like to have the gynecological examination. At-home testing, it might increase the HPV testing. Another area which is coming up, which is a risk-stratified or the personalized screening. Here you have your population, you do your risk assessment, you stratify them into different risk groups, and then you tailor your screening to each risk groups. And this is the evidence is so far that this will improve the benefit harm of the screening program and also the cost effectiveness. I'm giving a talk this afternoon on risk stratified screening only in the oncology symposium. Now, new cancer programs, the lung cancer screening is coming up in Europe. And this is a screening with having a low-dose CT. But again, as I said, screening is not just because we have CT machines, then we start doing screening. It's the way it's considered now in the UK to be introduced, you have a long list. One is to consider, it's going to be risk stratified. It's going to be targeted to people who are smokers, but there are different risk estimation tools, and need the decision on which tool you're going to use. But then it's also, will be integrated with smoking cessation program. And there is also a plan, if you're doing a CT, you're going to have incidental findings, whether in the lung or in the heart. There should be a management plan. Also, there is not every lung nodule will be treated, so therefore there is a plan of how you're going to monitor which nodules. There's a volume assessment and then follow up. And there will be, therefore, to increase an uptake, because usually smokers are higher, therefore more associated with deprivation and it's difficult to come. It's using of patient navigators, people that can hold hand of people to give them the direction and get them to come into community health workers to increase an uptake. And of course, we need to consider the behavioral aspects to participation. Here, we need to know that people feel that they have a capability, they understand what they are going to do. There is opportunistic, which is close by. This is why we have the vans, the CT scanning vans, to make it accessible. And there is a motivation that they know that they can do something about it. We need to look into from behavioral aspects in order to increase uptake. So all these are working together before we start the screening program. There's new technologies I'll go through quickly. There's new technologies that coming sometimes. It will be the multi-cancer early detection test. So currently we have a one test for one cancer. The future is holding that we have a one test that can identify more than one cancer. Some of them can identify up to 50 types of cancer types. And this is based on liquid biopsy, which is basically taking a blood sample. You don't need to take a tissue biopsy. And in this way, you can identify, from looking into the genetic profile, whether you look into the circulating tumor cells in the blood or circulating bits of the cells, which is the DNA or other or RNA particles. And there are multiple technologies are in development. It's very much driving the field. In the UK, there is a trial for one of them with one of the tests, and to see whether accordingly whether it's worthwhile having this screening. But once the results are out, still we need, once it is used, the cost of this test will come down. So it's not ready yet, but this is something to keep an eye on. Because of the investment in so many companies, this will happen in the future, I suspect. The other test which is coming as a screening, I suspect soon, is the cytosponge. Cytosponge is a pill with a string. You swallow it, and then once you swallow it, will open up, it becomes a sponge, and then once you pull, you pull it out, it will take cell samples from the esophagus. It's a way of screening for Barrett's esophagus as a precursor for esophageal cancer. Of course, I can't do a talk without saying, therefore, the role of the artificial intelligence, and, for example, in image analysis, and this is not a replacement of radiologists, rather than its help as a triage. But of course, there are challenges. One of the challenges, any algorithm is as good as the data it is trained on, so there is some work still going on. So in summary, I can say screening is a program, it's not a test. If you have a good organized screening program, some cancer types, there is proven evidence that they can improve the reduce cancer death, improve the population outcomes. But if it is not well organized, it's just a waste of resources. And how you run the program, it's the maker or breaker of the program. Thank you very much.
Thank you all. We're going to move on to the next panel.
Have them remember their questions.
Yes, I was going to remember them. Please remember that the question-answer session will be at the end of the next two speakers, so write them down, keep them in mind. Yes, that was it.
Hi, everyone. Very excited to move on with our second panel today, with two very important and interesting speakers who are going to be talking about other mechanisms to strengthen the healthcare system in Armenia. Our first lecturer, when you think about emergency medicine in Armenia, this is who you think of. Dr. Sharon Chekijan is an associate professor in the Department of Emergency Medicine at the Yale School of Medicine, and she's a faculty member in the section of Global Health and International Emergency Medicine, as well as in the section of Administration. Her research interests lie in global emergency medicine and include emergency care systems development in low and middle income countries, unintentional injury prevention, again in low and middle income countries, as well as stroke and cardiac care in those areas. Dr. Chekijan has led and participated in projects in the Republic of Armenia for a long, long time, as well as worked in Uganda and Iraq. She's currently a faculty mentor for an NIH-funded grant with the AUB in Lebanon, and she has consulted for the World Bank, U.S. Department of State, and others. Right now, she's an active member of the Stroke Initiative Advisory Task Force for Armenia and the Armenian Stroke Council. In 2020, she was awarded a Fulbright Scholar Award for her work to improve emergency care in Armenia by the establishment of a new emergency medicine residency program here in cooperation with the National Institutes of Health here in Armenia and the Turpanjan School of Public Health at the American University of Armenia. She's deeply committed to patient experience, communication, and humanism in medicine. And fun fact, Dr. Chekijan actually co-produced a film with Ani Hovhannisyan that addresses human rights as it relates to the Armenian genocide of 1915, and that film is called The Hidden Map, and I'm sure many of you have seen it. Today, she's going to share with us a talk about emergency medicine, past, present, and future in Armenia, and share her personal story with her involvement in emergency medicine here in the country. Thank you, and welcome to Dr. Chekijan.
Thank you, Kim. During this presentation, I'm going to mention a few people as I go through projects that I've worked on. And as Kim said, I am going to talk a little bit about emergency medicine in general, about my personal story, and then about the future of what we're going to be doing. So it's kind of a winding path that I took. I first came here in 1991 after the earthquake that occurred in '88. At that time, I knew only one person in Armenia, who I'm still in touch with, somebody who I went to Smith with and happened to sit next to me in class. After I graduated, I went to New York and I worked in industry at first, and then in public health at Columbia. I decided to apply to medical school, largely in part because of the influence of people I met in 1991. I went to Yale, and I graduated. I went to surgical residency, and I actually did 3 years of surgery before deciding that emergency medicine was more my style, that I wanted to be out in the world and dealing with real issues. And some of those issues I'm going to talk about today, just so you can see what the landscape is like for emergency medicine. I did EM residency back at Yale, and I've stayed on staff there ever since. I did my MPH following actually following my residency, so while I was already in attending. And I did that in healthcare and administration. So here's a picture just to give you an idea of why I came back again. I came first in 91, then I came back in 1995. On the left is Noravank, one of my favorite churches, but on the right is a church that I helped to reconstruct. And that is in Gogaran in the Spidak region. And the church had actually, it's from the 11th century, had collapsed during the earthquake. This is just a picture to remind us of what Armenia is like now, so the old and the new. And a nice picture of Mike Tyson that says, "One day I know I will explode." Why do I care about it? You know, this is my family's background is from Armenia. I think coming at that time, you know, right at the eve of the revolution, literally leaving the day before the coup on the Kremlin happened, really touched me. And since that time, I have really watched Armenia grow and really watched all of its transitions from a Soviet, you know, post-Soviet democracy through its entire reform of its economy. Really through all of these changes in legislation and healthcare legislation and in financing and really prioritization. And I think you've heard a lot of lectures the last couple of days, especially from the plenaries, about priorities, you know, that we could make in cancer screening and primary health care, a lot of competing priorities. And so I'm going to try and make the case for emergency care today. You know, as you know, we've gone through cronyism, the revolution, and now frozen and unfrozen conflict. So what is emergency medicine? So it is not, what is not, is Stop Oknu Champ, it is not Skori Pajishkuchun, it is An Hedezekeli Pajishkuchun. And so thank you to Shushanik, who actually wrote this out for me because it would have taken me years. But I just wanted to posit that and just to give everybody thought about, you know, the way we think about emergency medicine in Armenia is different from what emergency medicine really is. In fact, a good friend of mine even yesterday said, you know, why do all this work? You could, in 1 month, you could teach all of emergency medicine. And I'm looking at somebody now who doubts that. So what is it? It's any patient, it's any time, and it's anything. So it's all emergency conditions, really, from every single specialty. So it's emergency medicine is really, this is the true definition, is the medical specialty dedicated to the diagnosis of and treatment of unforeseen illness or injury. It also encompasses, and this is important for Armenia, planning, oversight, medical direction, and provision for the entire community for emergency medical response, medical control, and disaster preparedness. And we're going to talk a little bit about that at the end. And I know all of you probably have that in your mind as well. So what is EM? What does it encompass? You know, when we think about EM, we really think about it as the point of access for the big five. And the big five are really cardiac arrest, ACS, STEMI, trauma, cerebrovascular accidents or stroke, and we heard a lot about that yesterday, sepsis, and I would probably add respiratory illness as well. But it's also the specialty that deals with pandemics, mass casualties, and natural disasters. So just a little bit about the history of emergency medicine. You know, every country goes through this evolution of emergency medicine, and Armenia is on that trajectory right now. So these are pictures actually from Yale University, where I'm attending. And the picture on the far right is a picture actually of the first ambulance in 1888. In the middle is a picture of the first automated ambulance in 1913. And now our emergency department today, all the way on the left. And that's where I work. That's the entrance that I walk through every day when I go to work. So you can see that there's been an evolution even in our country over the last 100 years, but especially over the last 60 years as the automated cars have become more prevalent. We have fast highways. Emergency medicine has really been the specialty that has gathered all of these things together. If you look at the whole world map, you can see this is a map of where emergency medicine is recognized as a specialty, and you'll note red means that there is recognition. You'll note all of the ex-Soviet republics. So this is really the area that I'm very interested in, completely white. In other words, not much recognition. Our neighbors, Turkey and Georgia, actually do have this specialty already. Azerbaijan does not, and continuing through Central Asia, there is really a lack of emergency care. And this is an area that's really wide open, I think, for studying and for improving. So is it a luxury? Everybody says, well, this is the cherry on top of the cake. It's not. WHO is very, very involved now in preparing the rest of the world for emergency care, and it's estimated that about half of deaths around the world and 40% of the total burden of disease could actually be treated and solved with very good pre-hospital and emergency care. And I think that's important to keep in mind, because we did hear from Dr. Shekerdemian yesterday that primary care is important, and it is. It's very important for screening and for dealing with the everyday and for risk management. But for the things that are going to kill you, emergency medicine is where it's at. And even at home where we have, I can't even say we have very well organized primary care, but where we have primary care with a lot of resources, we still have an abundance of patients coming to the emergency department because they need imaging, or they need stabilization, or they need lab work. And so this is a very important part of the healthcare system. It's not something that we can just add on later on. We need to develop it now. This is a picture of the African Journal of Emergency Medicine with an article that was produced actually from Brown University, and the lead author is from Brown. And it really is looking at Rwanda and the institution of an emergency medicine residency program and its impact on morbidity and mortality. And they actually estimated, you can see in this last line, that there was a 43% reduction in mortality likelihood just from starting emergency medicine training. So where are we in Armenia right now? I'm going to talk about this a little bit, then I'm going to talk about some projects that I've worked on so you guys can get a real feel for what's been happening. And I'll try and do it quickly, because yesterday, Dr. Babloyan, I told him I had to go home and prepare my slides, and he said, why? You could talk for hours about this, and I can. So I did set my timer. So EMS in Armenia really struggles with a lack of resources. The structure of the ambulance system is really very heavily weighted towards Yerevan and not so much towards the regions. A lot of address changes, so names that changed after the revolution. People might say one name and you need to put something else into navigation. You guys have all tried to take Gigi, so I think you know about this. The infrastructure of the roads is particularly challenging, and most importantly, there's no residency yet. So this is a picture, you might recognize this lady, Dr. Stepanian, she's laughing. So this is a picture actually at the Central Ambulance Service in Yerevan, and you can see we actually have a pretty sophisticated GIS localization system that tells us which ambulance is out. You can see how many ambulances are out that day, if they're en route to the call, if they're on the way back, if they're on the scene, if they're going to the hospital, or if they're coming back to the station. And there's a map that Dr. Stepanian is standing next to with all of the substations in Yerevan, and I think there are, 8 now? 8 substations, she's nodding. This is a picture of the dispatch room and locator, which is this GIS system that I told you about. And you can see in real time that you can see where the ambulances are on the map at any given time. And these people are answering the phones, and it's one area that we could really improve. They're not giving direction or medical protocols. They're literally dispatching the ambulance. They're writing down information about the call, but they are not medical professionals trained to give dispatch advice. This is a picture in Stepanakert of an emergency department. This is actually the first emergency department that we had between Armenia and Artsakh. That has changed a little bit over the last several years with the advent of COVID and war. We now have approximately, I would say, 7 emergency departments, including one in Gyumri, and then several smaller ones along the border region that ICRC has been really key in establishing. Just a picture of Yerevan. So what have I done in terms of projects? And what do they all have in common? So they all have in common this sort of overlap between emergency medicine, systems development, the law, working with different entities here in Armenia to try and get them on the same page about emergency care. The first project I ever worked on had nothing to do with emergency care. It was organ transplantation. And I'll mention I came in 1999, and Dr. Babloyan was actually my thesis advisor at the time. He was the Minister of Health. I worked with Seva Gavakian and Dr. Davidians actually that summer, so some of the greats. Kim was around already in Armenia, and George Melikian and Adam Kaligian were there that summer, and we shared a round table at AUA and discussed all of our projects. So you can see the people that are still active then are active today. So the project structure, we really talked to professionals, the public, we passed legislation, we did a policy assessment, and we even got the church to weigh in on brain death. I'm not going to talk too much about that project just because it has not a lot to do with EM, but it was really the inspiration for all of my projects after that, trying to put the pieces together of all of these areas, professional, public, legislative, and opinions within different entities. So next, I worked on CPR. This was in 2005. I did a combined survey looking at cardiopulmonary resuscitation and also looking at EMS services, and I'm going to talk about the EMS part a little bit later, so I just disaggregated them here, but they were done at the same time. And the studies have actually been repeated in 2010 and then again in 2018, I believe, and we'll be publishing that information soon. So why CPR? It's really, again, that interface between EMS and the involvement of the general population. It was based at the time that we did the study that there were about 800 cardiac arrests per year in Yerevan. I'm sure that number has gone up. And we heard a little bit of data yesterday that within a 6-month period, I think there were close to 200 cardiac arrests. And, you know, it really stresses the importance of the chain of survival, which we talk a lot about in emergency medicine. So this rapid access to care or a 911 equivalent, immediate CPR, defibrillation rapidly, and transfer to a cardiac-equipped hospital. And then personal experience. I did have 2 people close to me that passed away from cardiac arrest and were not able to get treatment here in Armenia. The CPR project structure, again, like I spoke of before, focus groups, physician questionnaire, public questionnaire, and policy recommendations. And I'll just take a minute to say that everything that I've worked on in the past has really been sort of with the purpose of passing it off to the ministry or to the NIH as a way of being sort of a research or expert subject matter person for them, just because they don't, you know, it's a very small staff, and I know they're strained, and you heard about a lot of competing priorities. So I've always really tried to kind of taper what I'm doing to something that might be interesting to them and might lead to some change. So I'm just going to go through some of the key findings. When we talked to the public, actually 16% of them were medical personnel. 89% had heard of CPR, so that's 11% that hadn't even heard of CPR. 26% had been trained, and 82% were willing to perform CPR on a family member or a friend, and 76% said they would perform it on a stranger. So that means 25% would not perform CPR on a stranger, even if they knew it. It's a little bit alarming. 45% of people had somebody with heart disease actually in their house, and they still did not know how to perform CPR. But they were willing to learn, which was good. One of the cited reasons, or 2 of them, for not wanting to learn was a fear of bodily fluids, and then also a fear that they might not physically be able to perform the task. We also talked to physicians in the ambulance system, actually 181 emergency physicians at that time. Now there's close to 400 in Yerevan. And we did a self-administered survey with them. We wanted to know about their exposure and comfort with CPR. And I'll say 15% of doctors that we surveyed said they were very uncomfortable actually responding to adult call. But even more alarming, for pediatric calls, 80% wanted further training. So you can see a huge need. And that need has really gone unmet. Aline Bagdasarian did a great job training everybody in PALS back in 2016. But we do need to do refresher classes, and we've been working with Dr. Virabian very closely for many years now on trying to train the rest of the ambulance staff, and luckily last year Dr. Stepania made him the head of education for the group, and so we've had some success at doing that with traveling doctors, and Armenia is sitting in front of me. we trained over 200 people just several months ago. So I'm going to talk a little bit about traffic safety. This is one of my personal loves, and I hope actually to get back to this because it needs to be looked at again. And this is an area where emergency care has a huge role. Worldwide, 1.35 million preventable deaths occur every year and 50 million injuries. So when you look, it's really the leading cause of death for people between the age of 5 to 29. So huge morbidity and mortality, again, just like we heard from Dr. Pashan, at a time where people are in their prime, can be productive. We don't want to lose these people. It's going to be, by 2030, the fifth leading cause of death worldwide, and it does affect a very young demographic. The key here is the word preventable, so I'll stress that. And I also will add that 90% of injuries and deaths occur in low and middle income countries. And so you might have heard a lot about low and middle income countries when Kim was introducing me. Where Armenia lands right now, we started out as a low income country. We're actually a high middle income country at this point. So we're really, about to jump off the spectrum, which is exciting. I know a lot of people are surprised to hear that. And again, this project also was at the interface of emergency medical systems, legislation, and road infrastructure and engineering, which is really exciting. And again, it emphasized that chain of survival, so a very exciting way for emergency medicine to intervene. This is a paper that I wrote, not about Armenia, but about the global burden of road injury and its really relevance to emergency physicians around the world. This is probably my most cited publication. This is a picture, just a heat map of where injuries occur, and you can see we're right in sort of the hotbed of injury, and Africa is really the worst of everything. But you can see in terms of deaths per 100,000 inhabitants, you can see that we actually are really in that higher range, and I'll just show some data in a second about that. Good. Okay, the numbers you can see. So you can see where Armenia lies in terms of former Soviet republics. We have 17.1 per 100,000 population crash fatalities. These aren't even injuries, guys, so you can think about all those crashes that you see. These are fatalities. So every one of these is preventable. And you can look around the world, you have 18.2 as the average, but you have things as high as, I think, Dominican Republic, something like 68 per 100,000, so it's definitely off of my list of places to vacation or visit. Azerbaijan claims actually to have a rate close to 6, whereas 2 years ago it was 18, so I have some questions about the validity of their numbers, but just out of interest I mentioned that. So some of the modifiable factors in fatalities, really speed, driving under the influence, seatbelts, child restraints, and helmets. Those are the big 5. Speed is the worst. If you had to pick one thing, it would be speed. And the most effective intervention I'm going to talk about in a minute. And obviously speed, especially in cities, can be fatal for pedestrians. And so I really was very interested in what I could do in Armenia. Let me just mention this before I move on. This is legislation that covers those big 5, and only 7% of the world's population is actually covered by legislation to protect them against those big 5 reasons for injury and mortality. Armenia is really, that's again that links between EMS, et cetera. Armenia really has a lot of challenges in this area. Roads, which you can see a lot of roads are being redone right now. An aging fleet of cars. You can go to Gyumri, as we did the other day, and see some very old cars still on the road from 30 years ago without very good safety devices. So little by little, those cars are being replaced, but they are in use in much of the country. There's this cutting of seatbelts. You may have noticed this when you get into a car, or tucking the seatbelts in so that they can't be used. That's very particular, actually, to Armenia. Some picture of some old Soviet cars. These were all things that I saw, while I was here on the road, so still in use. Weird things I've seen. Strangely enough, only have seen this in Turkey and in Armenia. This sort of wrapping the belts to stop the alarms from going off. So even when you have a newer car, where safety features should save you, people still find a way to bypass it. And here you can see, and this is not uncommon, something you could buy at the store that you put in to stop the ringing and the dinging when somebody sits in your passenger seat. This is the one time I saw seatbelts well used. My husband, we had bought wine, and he was concerned about the wine. So, A lot to be done. So what was the state of legislation in Armenia at that time? There were really laws in place only for the front seat driver to be restrained. The passenger did not have to be restrained. Children under 12 had to sit in the back, but there was nothing to govern restraints in the back seat, so very dangerous. And there was a pedestrian right-of-way law, but it wasn't observed. And if anybody remembers being here 15, 20 years ago, it was almost impossible to cross the street. And that's why I became very interested in this. So we did, again, a public survey, focus groups. We looked at crash data. We GIS localized hotspots, which I'll show you, and made some policy recommendations. And there's so much work to be done in this area. And this is really a hot topic right now for WHO. This is like they had like the decade of road safety. This is the second decade because they had zero success. But in that zero success, they also had a lot more motorization, a lot more mobilization of people. So it maybe if things had stayed the same, it would have looked a little bit better data-wise, but it did not look good. So we did a random digit dial survey, and we called different households, and we asked them if they were aware of different laws, rules, what their personal practices were. And I'm going to go through this quickly just because we don't have a ton of time. We had some very interesting things happen. Nune Truzian, who I work with at AUA, and Kim will know very well, she actually called me after we had done this survey and I had returned home, and she said, you know, we have to do this whole thing all over again because everything has changed. And I said, what happened? And she said, I don't know, they're enforcing all the laws that we were asking about. People are behaving differently. They're putting their seatbelts on. They're stopping for pedestrians. They have barricades up. And we found out actually that when we did our survey, we called the head of the police's household. And he was personally offended and, you know, that these things weren't being enforced. And so he told all of his staff, listen, we have to enforce these laws. So reaching that one person actually had this huge effect. And Nune wanted to throw out all the data. And I said, no, let's not throw it out. Let's just redo everything, which was really painful. She didn't want to do that. But we really actually redid the whole survey to see if there was a change in terms of knowledge. And there was, actually. So initially, safety belt usage was very low. 21% as a passenger wore their belt. Post-intervention, the number of people wearing seatbelts went up to 81% for drivers and 69% for passengers. Awareness of the law went up from 76% to 85%, so again, statistically significant. Just some weird things about Armenians. They think that when you are in the city, you don't need a seatbelt, but if you're going long distance, you need one. So this is one thing we uncovered, which is interesting because people still say that to me now. And they said they're more likely to use things when they leave. We had a lot of work to do, and we still have a lot of work to do in terms of child safety restraints. There was actually almost no safety restraint usage or child, the seats that we see, and that's in large part due to expenses involved and also the need to put a lot of people in one car when you're traveling. It makes it very hard to have one seat occupied with a safety seat. So lots of work to do there. 86% of the time that we surveyed believed it would be possible to actually drink and drive, and so you can see that that enforcement needs to be improved. This resulted in a paper that we wrote about attitudes and perceptions towards road safety in Yerevan, which is one of my other most cited articles, and actually is my favorite article I think that I've written. This is just a map, and actually the folks at AUA and the bird migration department helped us because we were early on in GIS mapping, and we mapped out all the hotspots in Yerevan for crashes, and we fed this information back to the police and to the engineering department. It'd be nice to redo this if anybody wants a project. I'm looking at the guys over there that want a project. So progress, the National Road Safety Council was formed, the road safety plan was drafted, but again, tons of work to do in this area. We have not budged the needle in terms of fatalities in the last 10 years or so. In EMS systems, we ask a lot of questions, again in that same format, to the public about their use of emergency services, and also to doctors on the ambulances about their beliefs about being able to take care of their patients. So 30% of doctors themselves thought it was safer actually to call, and these are ambulance doctors, right? Safer to drive to the hospital than to call for the ambulance. 99% said they would treat people without asking for money, which is great. At that time, this was not covered by the Ministry of Health, although emergency calls are covered now. And 47% of the doctors working in the system thought that there were major problems with the system. This is longitudinally. We redid this survey several times, just a graphic of those questions. And also just to say that we did work on Locator, which is the ambulance service database, to see if we could pinpoint response times and see how they looked in terms of standardized expectations globally. So more to come on that. We wrote this up about emergency medical systems and directions forward from here, post-transition. And most recently, I was asked to join CIATA, so one of those other big 5 issues, neurology and stroke. And that's the stroke group that you heard of yesterday from Vikan Babigian. And I'm not going to belabor the points there because Vikan talked extensively about stroke care in Armenia, just to say that I joined the group as the liaison between emergency medical systems and stroke care. Armenia lies really in the higher point. We're about 4 times more likely here to have a stroke than in the US. So kind of dire information. Current treatment options, which she went over a little bit yesterday, are just medical management, thrombolysis, and then also endovascular therapy, which is really state of the art. Actually, in most of the US, you could not have endovascular therapy. The Ministry of Health is actually covering those treatments. So this is a huge kudo to them. So if somebody's having a stroke, they know that they'll have coverage and they're more likely to call the ambulance and they're more likely to get taken to the proper hospital, which is great. So we're really trying to strengthen that chain, that link in the chain of survival again. We really need to do a lot with public education on when to call for stroke. And this is really the next area that I'm going to be looking at in terms of data and writing something up. So in terms of EMS, these are just some things: checking glucose level, getting the story from the family, getting the last time known well, making sure that all of the airway, breathing, and circulation issues are addressed on the way to the hospital. This is really the role of emergency medical systems in this. Armenia currently doesn't go through one protocol to assess for stroke, so we need to decide which one to adopt. For instance, like Cleveland criteria, to actually rate people to see if they have a large vessel occlusion. So much more to come on this. I think we'll probably do a pre and a post assessment and an intervention in between for the ambulance physicians. We wrote this up as part of the CIATA group, and you saw this yesterday about stroke care in Armenia, and there is a section on EMS and its role and what we need to improve. And in terms of next steps, you heard from Kim about a Fulbright, which I just finished. I had it actually before everything happened here in Armenia with COVID and war, so I'm going to talk about that. It had to be delayed by 1 year, and we're just wrapping up all of those recommendations. I'll just go through the phases. The first phase was really to advocate for the specialty. Right now we have the specialty of emergency medicine on the list of recognized specialties. It was supposed to be improved last October, but is still pending, but hopefully before too long we will join that map that we saw of Armenia recognizing emergency medicine as a separate specialty. We are working with the NIH currently in phase 2, doing curriculum development for a new emergency medicine residency program, doing capacity building at the hospital level to make sure that the hospitals are ready to expand their EDs and take care of patients. As there's most of emergency care is largely based on ambulances still here and not in hospitals, although that is changing. And phase 3 will be research capacity building, so synchronization of databases so that we can get baseline data and do ongoing QI and improvement. And coming soon, we're going to have an 18-month short concept residency program for people who have already graduated from a first specialty. It's going to be located at the NIH, and I see Dr. Bazarchan there. And he's been really key in pushing this forward, and we're going to launch in September. It's going to be a unified program, meaning that we're not favoring one clinical base or another. We're going to work with all hospitals that want us to work with them, and specifically all hospitals with emergency care or who are planning to build emergency care. So I just wanted to mention the curriculum that we've been working on, and Oriane Longerstay, who's a physician from Brown, is here in the audience. This is her work. So you can see month by month, this is the first 4 months, week by week, all of the subjects that we're going to be covering. And essentially it's all emergencies for every single specialty. And then we'll have lectures once a week virtually. So we'll have some in-person components and then a big virtual component. And so we're trying to pick, that's my beeper. We're trying to pick very, very motivated people that are going to be the leaders in emergency care and bring this forward so that eventually we'll have a 3-year program directly from medical school. So another Mike Tyson quote, everyone has a plan till they get punched in the mouth, then they have no plan. So our plan was really, to do emergency care and do it well, and then we had a whole series of events. Here's our bad neighborhood, just to remind you. Armenia is particularly prone, actually, to disaster, so I just wanted to say a few words about this. In our recent history, this was actually a slide that I made before we were attacked again. We've had earthquake, we've had COVID, we had the war in Artsakh, the first war. Recently, we had the events in Artsakh in 2020, the 44-day war, and most recently, the blockade and a humanitarian crisis. We wrote about this, actually, in Dr. Bazarchan and I have a publication, a violation of the global ceasefire. The UN had asked for a global ceasefire, and Azerbaijan obviously went against all international edicts and attacked us. And you can see this is a plot just of COVID cases. Everybody here was doing a great job managing this, and you can see the inflection point of the first day of war when cases went crazy, and you can also see when there was a truce how cases started to come down. So kudos to everybody here that was able to work on that first part of COVID and really keep cases down, and then things spiraled out of control. So just a word about disaster. Disaster is defined as any occurrence that really exceeds the capacity of the system to deal with it. And this is where emergency medicine really excels. It's really that systems level work. And this is where a lot of work needs to occur. And I'm just going to go through these. There are a lot of critical elements for hospitals to be ready. And I think Laurence is here. She's from the ministry. She's going to be working on this quite a lot, so this is going to be very important work. And there's actually been already a lot of work in this area. And I had forgotten about these reports, Laurence, and so these are important. You have to take a picture of the screen because there are actually 3 reports already for Armenia on emergency preparedness and crisis preparedness at a health systems level. And so these should really guide us. They've been done by international organizations, and there's quite a lot of good information here. WHO, as I've said, over the last several years has really invested a lot in mass casualty training, emergency teams development, and a whole toolkit for emergency medicine. And that's in large part due to our colleague, Terry Reynolds, who's in Geneva now running that division. Actually just got promoted because of her great work on basic emergency certification, which is available to every country now and is administered via ICRC. So a lot of things to do, a lot of things ahead of us, and I just wanted to say thank you to everybody, especially to Dr. Babloyan, Dr. Davidians, who's not with us, unfortunately, Seva Gavakian, Dr. Bazarchan, Vartuhi Petrosian, the Dean of the School of Public Health, Anushavan Virabian, Dr. Stepanian Takuhi, Vice Ministers Nanushian and Anahida Vanessian, Nune Trusian for her careful work, to Orion for her work on the curriculum, and to Gevorg, of course, and then to everybody who's here. So we have a little contingency over here of folks very interested in emergency medicine. So we're laying the groundwork for the future, but you can see where all the areas are for improvement. Thank you for your attention.
Չեմքներ ով է որ Zoom-ի տեխնոլոգիին պիտի բանանի, բայց մինչև որ մենք Հարություն Արմենյանին կանչենք Zoom-ով, Dr. Babloyan-ը մի քանի խոսք ունի ասելու, ավելեցնելու Dr. Չեքիջյանի մասին։
Այո, նայեք, մեր համագումարը հետարքիր ֆորմատ ունի եւ մարդիկ, որոնք